Hello, I am Eduardo Anitua from Spain, Vitoria, for Dental XP. The first topic that I want to share with you today is the new instrument. Is the BTI expanded drills. That is a new instrument, a new philosophy to treat the very narrow crest. The idea is to use this specific instrument for the anterior area and this other short instrument for the posterior area. We developed this instrument one day that I finished one surgery, and one of my patients told me, Eduardo, really I don't like at all to use the mullet in my mouth. For that, I developed this technique that I think that is very easy technique that everybody can incorporate tomorrow in his office. The idea is when we have a very narrow crest, we design one specific flap, we open a full flap, and we use this specific instrument. This drill that we can see is one specific drill that we developed, is our patent, is original drill that have the capacity to cut in very precise narrow crest. It's possible even with this specific drill to cut laterally or have a very aggressive apex, and it's possible to create the right direction. After we introduce the first expander and the second expander. In the moment that we finish the expansion crest, using this specific instrument without irrigation at 50 revolution, is the time to introduce the implant. We use this specific implant with one specific apex that have the capacity to advance and the capacity to introduce in a very narrow crest are the BTI implant design. After is the moment to study if the flap is possible to close without pressure and to overcorrect the expansion. My concept is always to obtain expansion to overcorrect 1 or 2 times. Why? Because sometimes in a very narrow crest makes sense to obtain better lip support, to overcorrect and overcorrect to offer better lip support. Now I want to show you one video with the technique. This is a really narrow crest, 3 millimeters. We start in the scanner. I start with the first drill and I use the first expander. With the first expander, we can observe how open the crest. We remove. I am using the instrument at 50 revolution without irrigation. We introduce the second instrument, and we can observe how the crest open. Look at now what happened with the bone. I remove the instrument, and always the third expander are the implant. For that I use this specific design of the implant with a conical apex and with one propeller in the apex. We wet the implant and we fill the alveolus with the PRGF, with autologous protein of the patient. I obtain a good premolar stability. This is the bone that I recovered during the drill sequence, that is a small quantity of bone, and now overcorrect using free trace bone with PRGF. Look at the consistency of the bone when I use the PRGF, and look at the membrane of the fibrin that we prepare with the PRGF technique. Always I contain the graft with the autologous proteins, with the autologous membrane, and I suture. This is the X-ray. When I reopen after 4 months, we can observe the bleeding, how the bone is a live bone. Look at the bone regeneration. This is one case that I like to show because it's one case with 5 years follow-up. We can observe the stability of the soft tissue and the hard tissue. One of the big advantages is to use this technique not only in a really narrow crest. In many cases when we are in class 3, we have the possibility to maintain the buccal wall. Why? Because many times when I reopen, sometimes I lose bone in the buccal area. Why? Because don't have the thickness that is necessary to maintain the stability of this bone. If we do the expansion of the crest, it's possible to maintain much better this quantity and quality of the bone. One of the other big advantages of this technique is to use in the mandible. It's impossible to use the osteotome. I was using for years the osteotome, the rubber summers, but today this instrument have the advantage that it's possible also to use in the mandible. The technique is exactly the same. We start with the first drill, I continue with the first instrument, with the second instrument, and I finish with the implant. Always in the mandible it's important to overcorrect, and in the mandible that always we are in a worse condition, I recommend to use autologous graft. Always I take bone of the ramus of this area, or many times during the drill sequence in the neighbor implants, and I overcorrect, and sometimes I overcorrect also with one biomaterial. Sometimes this is bios. I like it to use the bios when I need a slow remodelation that can support very well my graft. But always my first graft is to use autologous bone, and after overcorrect with one biomaterial. Look at the quality of the graft that we can prepare with the PRGF. The concept is always to finish with the implant. When I use the two first instruments, I continue with one implant, the 3.3. If it's possible to introduce the third instrument, I continue with one implant, the 3.75. Many times for a sinus elevation, for the Summers technique, it's possible to use this instrument and introduce after the 4 instrument, the 4 expansor, one implant, the 4 millimeters, 4.5 or 5 millimeters, depending of the crest of the bone. This is part of the technique. If we use this specific apex, it's very easy to introduce the implant in a really narrow crest. This is the apex of the VTI that we developed, that the concept is the first, the apex is one propeller that has the capacity to advance, and the second is the conical design of the apex. Why? Because this apex have the capacity to cut the bone and never push the bone against. Always the bone maintained in the apex. If we compare with other apex of the market, in a very easy case, it's possible to use maybe many implants, but when I am in a very narrow crest, not all the design of the implant have the same capacity to introduce in a very narrow crest. Look at this case. It's a really narrow crest. I open. I start to do the expansion. The last implant was very easy, but look at the first implant. It's a big expansion, overcorrect with the graft, and always overcorrect with the fibrin membrane. Look at this other case. It's a big fracture, maybe 45 degrees, the buccal wall. I overcorrect with the graft that I recover during the drill sequence, and after I cover with autologous fibrin. In this case, I do immediately loading in the neighbor implants. When I reopen, always we find exactly the same. If I broke the bone and overcorrect with the bone, always we find bone. Cases like these are very predictable cases. Overcorrect with autologous bone, cover with autologous fibrin, and always we find exactly the same. Sometimes for aesthetic reason, or sometimes maybe I can overcorrect completely the implant, it's possible in the second stage overcorrect again with the graft that we prepare. Look at this case. It's a really narrow case that now it's possible to introduce all the implant in so narrow crest. But look at this case. This is a very narrow mandible. Which are the options that we have? To use block. I love the block. But if it's possible to use a very easy technique, my patient always prefer a very easy technique like the expansion crest. Look at, I convert one crest, the 3 millimeters, in one crest open. That is possible to introduce one implant, the 3.75, and after I need to overcorrect always in the mandible with autologous graft, and after overcorrect with one biomaterial. This is the design of the implant that we use today in our office. There are many different diameters depending on the crest. And the concept is that always the implant are the last expansor. Thank you for your attention.